Okay. All right. So we'll be getting started in a few minutes. Just in case you guys don't know me, my name is Nihal Desai, and I might be just going over some um, topics and to use as a review guide for your exams. So, um, just wanted to give you guys a few minutes. If you had any questions, feel free to um, put it in the chat here, and we will look more into it um, and get back to you on that. So, just a few more minutes, and then we'll get started. There's quite a bit of things that we have to discuss, which I won't be able to discuss everything in this lecture alone. So we'll be going over uh, a wide variety of things. Um, you know, uh, as as we go. So it's this is just you can consider this as a part one of the NAPLEX live lecture overview. Um, because this is going to be kind of like a mega review of a lot of content that we have discussed so far since the beginning of the course. And so I hope this has been somewhat a um, useful experience for you all. At least you guys had you have been keeping up with the videos so far. Hopefully, they have been providing some valuable information, not just for passing the exam, but also um, for your practice as well as you um, work and your daily um, life. So, like during those times, it's important to at least have an idea as to what medications used, how they're used, what they're used for, and understanding side effects and all of those things. It is also important to understand how certain calculations and why certain things are clinically more relevant than others. Um, some of these um, uh, informational um, things will be discussed in the future presentations as I give them. Um, so I hope you guys all will find this very useful. Not only it's going to be useful for you, but I hope it's going to be useful for those who are future graduates as well. I highly recommend at least um, taking the time to look over this stuff, and you know, keeping the pharmacy practice moving forward, and helping our patients um, in overall health, and also keeping medications, safe, um, and all of that. Patient safety is very important. Preventing errors, finding drug interactions. So, and counseling, which is also extremely important. So definitely, you know, utilize this stuff. It will help you all out, and we will continue to add more content um, because um, some of you like looking at um, certain things another way. So, and others might want to just learn something again, um, so I hope the informational sources um, become very relevant, and that you guys are all um, able to use that information for your studies as well. Um, so with that being said, does anyone have any questions before we get started here? So again, my name is Snehal Desai. This is our first part, you could say, of our NAPLEX live lecture overview. We've kind of already gone through these topics here, but for some of you, you guys may not have seen them, so we'll go over some of these things again. I might not be able to get through everything before, um, for the end of the day today. So I'm going to try to see how far I can get. Trying to get through a lot of this stuff, and it's kind of difficult to teach, especially for those um, who want to see more of it than hear it, and then some of you want to read more of it rather than hearing it, or things like that. So I'm going to do my best to provide content to you all both ways, um, so that you guys can first hear what I'm going to talk about, and then um, I will also show you as well, or at least try to do both at the same time if I can. But anyways, just to go over some reviews here. Um, you've already seen some of these topics in some of my lectures, or you've heard about them while you're in class or during your NAPLEX reviews. But we've kind of already talked about Alzheimer's disease, anxiety disorder. We talked about some bipolar, migraine, Parkinson's, depression, all these things that deal with the central nervous system and um, its parts. So, like ADHD and seizures, epilepsies, And I'm sure some of you have seen how, like, in Alzheimer's, um, you definitely don't want to give someone medication that's more like an anti um, or like anything that will affect like their memory. Um, so you already saw some of these medications utilized like donepezil, rivastigmine, galantamine, memantine, all of these medications that you would utilize to help um, prevent the progression of Alzheimer's disease. Um, then we already talked about some anxiety disorders like SSRIs, escitalopram, Lexapro, citalopram, things like that. Benzodiazepines, which obviously, when it comes to benzos, you're going to be um, increasing that inhibitory part of that nervous system. So sometimes, when there's higher mania syndromes or things like that, and there's a lot of things going on, sometimes there needs to be some kind of inhibition there. So benzodiazepines will help do some regulation there. Buspirone, beta blockers, there's some beta blockers involved in there too. So it's kind of interesting to see um, some of those mechanisms as well. Um, then you got mood stabilizers like lithium, atypical antipsychotics. Um, so then the migraine medicines, sumatriptan, rizatriptan, Ubrelvy, Nurtec, those kinds of things. Some OTC options like aspirin, ibuprofen, acetaminophen, or Tylenol. Um, just want you to guys understand, if you ever see a case question on OTC medicines, you definitely want to make sure that you look at the dosing, especially for Tylenol or acetaminophen, because um, definitely don't want to exceed that maximum gram or gram amount, that 4 grams of acetaminophen or like 3 or 4 grams of that. So definitely want to look at that. I also recommend to take a look at the other medication list to make sure he's not on any other medications that contain acetaminophen, such as Percocet or Norco. Patients normally would be on 1 or 2 pain medicines. Um, so you want to be careful on all of that. I can point out a few things here. Aspirin, be careful with aspirin as well, especially for those who are younger, where, so to prevent something like Ray's syndrome and those kinds of things. Ibuprofen, note the bleeding risk as well. Those kind of things here. Antipsychotics is pretty interesting too. Typically, the second generation antipsychotics should be first line for therapy for someone who having schizophrenia, for example, or psychosis. Generally, it's because of the way of it works, second generation, two receptor, second receptor. So you can just think of it like that. But I want you to be careful here, because some of those second generation might have other side effects too. Might also hit other receptors as well. So I don't know, I may have already talked about it, but I do think you guys should all know about that too. Um, Especially one I listed here, quetiapine or Seroquel. Sometimes, when they block the histamine 1 receptor, you're actually going to kind of um, cause patient to get more drowsy or more sleepy, so they might be using it for sleep, when in fact it's an antipsychotic. It's used to prevent schizophrenia. So it will also kind of block the serotonin and also the D2 receptor, dopamine. So I just wanted to list that out to you all, so at least you guys can have an idea, as to what is the best antipsychotic for that patient's um, treatment scenario and all of that. So do kind of expect, at least taking a look at that. If you get a case question on the exam about that, just understand um, what the second generation antipsychotics are, and um, some of the defined side effects as you guys are reviewing that. Um, Also understanding, some ADHD medications. A lot of times they're controlled substances. Methylphenidate amphetamines are controlled substances. And yes, they're used for ADHD. And so it's, important to at least note that what the regulation here is, not to be overdosing or giving too much of that medication to a patient. And then for seizures, normally when it comes to seizures, you probably see a lot of firing for excitatory neurotransmitters and like overexcitement. So they kind of use some of these mechanisms to prevent that overexcitement of the neurotransmitters. So if you looked at one of my videos earlier, I showed you a diagram that kind of broke down all of the medications all in one picture. So I'll show it to you again in a future presentation in this live lecture series. But these medications are really just to prevent that action potential from being generated, or at least kind of delaying it in one way or another, so that it doesn't continuously fire those neurotransmitters, or um, to or overexcite the receptors. So you can see how I'm kind of talking to you in a little bit of easier language here. But I want you guys to understand more of the medical side or the pharmacy side of it too. So, having to block sodium channels or having to block potassium channels, those kinds of things. At least understand the mechanism behind it, which will help you understand some of the side effects that a patient could have, some of the um, medications that can alter the function, and those kinds of things. So keep all of that in mind. Um, Beta blockers, you see under anxiety disorders, beta blockers. Also very basic concepts here. Beta 1 versus beta 2 blocker. Beta, like metoprolol-succinate, metoprolol tartrate, those two are beta blockers, but the purposes aren't exactly the same. Like metoprolol-succinate is going to be your extended release formulation, and metoprolol tartrate is going to be your immediate release. So you have to know those differences there. What else can I say? Selective serotonin reuptake inhibitors. Just by the name itself, you already explained the mechanism of action. of your anxiety disorder or depression medications. So, those kinds of things. And one common benzo that most patients will get is usually something like alprazolam or Xanax. So, and that is a control medication as well. So just wanted to um, give that to you so you guys know about some of these things. Um, I think that's pretty much all I could see here. Parkinson's disease, carbidopa, levodopa. I think we already discussed about this previously in one of my other videos. But the levodopa is essentially used to convert to dopamine once it gets through the blood-brain barrier. And the way it's going to do that is it's going to go through those kind of transporters, get out into the brain, and then going to go into neurotransmitter, convert to dopamine. But dopamine is also converted within the blood-brain part of it. So before it gets through the brain, it can also convert to dopamine. So that's where the carbidopa is going to help with um, prevention of that breakdown of levodopa. So just kind of understand, how the mechanisms are here. And I think that's all I can think of. But if anybody else wants to add on to it, feel free. I highly recommend you guys use this chart to at least put your notes all over it, so at least you guys can use it as a review guide. Allergies, rhinitis, cough, cold, antihistamines, those kinds of things. What did I just say earlier about histamine blocker? Blocking the H1 receptor, the histamine blocker. It's going to lead to more sedation, which is related to antipsychotics, right? So, like quetiapine, Seroquel, for example. But you also have antihistamines now. Antihistamines can also cause more sedation too, so drowsiness. So, what can you relate between antipsychotic and an antihistamine or allergic? Should you be giving a patient too much of that? Should you be giving patient an antihistamine that causes drowsiness and an second generation antipsychotic that will also cause drowsiness? I would not recommend those two together, because then the patient's going to be really feeling extremely drowsy. So the best thing is to find a non-drowsy allergy relief over-the-counter medicine if they're going to be taking a second generation antipsychotic that would cause drowsiness. So just, be aware of those kinds of things too. Some of those drug interactions are based off the mechanism that I just discussed to you. So that's why I said review, review, review all of these mechanisms, because that's how you get these things thinking. Cystic fibrosis, CFTR modulators. I'm sure you've seen like how it kind of blocks, that part where it will cause more of the bacteria and those kinds of things to kind of prevent some of the airways from going through, and all those kinds of factors there. So kind of just understand these mechanisms. Most of these other ones aren't really majorly topics, but at least have a general idea of how they're used, um, mechanistic wise. Pulmonary arterial hypertension, like prostacyclins, epoprostenol, treprostinol, and then the endothelial receptor antagonists, um, bosentan, ambrisentan, um, and then the SGC stimulators. So, all of these things are just to make sure it's kind of like vasodilating so patients, so blood can actually flow through. Because hypertension is essentially high blood pressure. And so um, we just want to make sure that it kind of opens up so that the flow in the blood or airways can go through. So, just keep a general understanding of those kinds of things too. Um, I did want to point out something about the endothelium. So the blood-brain barrier also has endothelium um, cells. That's actually the protective layer between the blood flow and the brain. And so between those endothelial cells, you have these things called tight junctions. That's actually going to kind of protect the brain from receiving all those um, other things that's going around in the blood. So if the endothelium cell was weakened, it's going to allow a excess amount of toxic or some toxic to go into the brain. So in order for it's always important to make sure that we have those barriers strong enough so that these kind of toxic molecules don't get in there. So um, now there was a theory that I think I read about somewhere online that discussed about, and this has nothing really much to do about any of these topics here, but like for cholesterol, that some patients are taking some statin medications. Um, there were two theories that I read about here that I think it would kind of get you thinking a little bit how certain statins may lead to headaches. And as I mentioned, cholesterol is essential, and this is why I kind of think you all should kind of understand um, the cholesterol is not just going to, it's not just something that you have to watch out for. There's good cholesterol, there's bad cholesterol, and you guys know this, that there's HDL, there's the LDL, and you know, cholesterol is also essential for like cell stability, cell growth. I'm sure some of you all have learned some basic cell biology on all of that, and like structure and functionality of the cell and all of that. Um, so there was something I thought was interesting about like certain cholesterol medicines as um, they can have some sort of effect on the brain too. Um, Two theories that I read about here, and I think you all might start to think about this. You might have questions on it too. Um, One is that there is um, that cholesterols are typically used to reduce the LDL or the bad cholesterol, and it essentially is reducing cholesterol. Cholesterol, like I mentioned, is like a stability and functionality of like cell structure and growth. But if you're going to reduce cholesterol, you're also going to make the endothelium cells weaker. So that can actually kind of also play a role in reducing the um, uh, part where like the cells get weaker in the blood-brain barrier so things can go through to the brain. The secondary is certain statins are lipids. So, and this might not should be a theory, it might be true too. The certain statins are the lipids. So lipids are able to cross through the blood-brain barrier, um, versus a polar molecule. So whenever that happens, that's another reason why patients might be experiencing headache. Again, these are just theories. These aren't really true, but sometimes you could see how someone might be experiencing headache because of a statin. Um, Statins typically cause muscle pain, but that does not mean it can't cause any other side effects. But the mechanistic theory was very interesting to me, so I thought I'd share it to you all so you guys can kind of look at things a little bit differently here. Um, then you have sleep disorders, temazepam, zolpidem, Zalplon, Ramelton. These, yes. When it comes to sleep, definitely don't want to give something that's gonna be drowsy as a treatment for, psychosis, and give them sleep disorder and give them some allergy medicine that's gonna cause drowsiness. That would not be good. So, um, just wanted you all to keep that in mind, um, how those kind of can interact there. And then you have asthma treatments, albuterol, fluticasone, um, formoterol, salmeterol, lanterol, Ventolin. Um, when it comes to asthma treatment, albuterol, some of you might see a DUR on the screen, how albuterol might interact with some other meds. That's true. There is a side effect there, or at least, um, as some of you might have read in your books, like the albuterol um, may actually cause a um, decrease in the potassium levels. So, um, for someone that's taking something to decrease potassium and albuterol, um, would not recommend that. So, um, just kind of understand those kinds of different mechanisms there. Um, then ipratropium as well, tiotropium, those anticholinergic mechanisms added with the albuterol so that, patient's COPD um, doesn't get worse. So, just keep those in mind. A lot of times when it comes to COPD, gotta add that corticosteroid. Um, that's just going to help with the inflammation. Albuterol by itself is typically used for like a rescue inhaler. Um, and also, the number one reason why COPD would occur is due to smoking. So just also keep that in mind too, smoking. And also, one thing about smoking is understanding smoking cessation, um, and those kinds of medications, Nicorette, nicotine patches, you know, so that, nicotine is not overflowing, it's actually kind of regulated. Um, so again, prevent that overstimulation. It's kind of like seizures, prevent overexcitement, overstimulation of glutamate receptors, and those kinds of things. So some of those mechanistic concepts can kind of stick here with when comparing one disease state with another. Then you have arrhythmias, beta blockers, calcium channel blockers, flecainide, amiodarone, sotalol, diltiazem, verapamil. Now, when we talk about those two medications, diltiazem and verapamil, those are not non-dihydropyridine calcium channel blockers. So, understand that um, and know the difference between that and the dihydropyridine calcium channel blockers. You wouldn't give someone a non-dihydropyridine calcium channel blocker to someone having chronic heart failure, but you could give someone a dihydropyridine calcium channel blocker, especially for those who have high blood pressure. So those are kinds of things you might want to understand. Typically for chronic heart failure, ACE inhibitors, ARBs, beta blockers, SGLT2 inhibitors. There's a few others that's used for heart as well. It's also kind of important to know those. Then hypertension, diuretics, ACE inhibitors, ARBs. So you can see some of the repeats here. I also want you guys to understand that when it comes to Entresto being one of those medications that contains sacubitril and valsartan. Now, that's the one of those ARBs in there. So, two things you want to watch out for is one, when switching from Entresto to ACE inhibitor, you do have wait for 36 hours. There's a 36-hour wash out period that has to be done before switching. And then the second point is definitely look out for any duplicates there. Sometimes the Entresto, because of it has that valsartan in there, there's an ARB. Make sure patients not take any ACE or ARB while they're taking Entresto. And then look out for that 36-hour period when switching from Entresto or switching to Entresto from an ACE inhibitor. So just note that. Calcium channel blockers, one thing I can point out here is definitely watch out for that amlodipine, or watch out for any dihydropyridine like amlodipine where it can cause swelling in the legs. Sometimes patients might be taking a water pill like furosemide to reduce the swelling in the legs, but furosemide can also decrease potassium levels. So watch out for someone taking while they're taking albuterol. And also so just kind of watch out for all of those things. Then for renal disease, they might be taking some phosphate binders, iron and erythropoietin stimulating agents. These, because patients are not able to definitely eliminate or have the normal elimination rate, glomerular filtration rate, creatinine clearance. You guys need to look at the values and normal values of that, and what medications are okay to take while they have these kind of renal diseases. One such monitoring parameter, for when it comes to medication for patient with chronic renal disease is definitely understanding the value of, how vancomycin is dosed. So understand vancomycin dosing, and also um, that aminoglycosides as well, the dosing for that. Aminoglycosides is also a nephrotoxic type, or can cause nephrotoxicity. So definitely want to keep that in mind, the dosing with those two. Anticoagulants, heparin, DOACs, direct oral anticoagulants like rivaroxaban, Xarelto, Eliquis, Pexaban, and Bigatran, vitamin K antagonist, warfarin. I think when it comes to warfarin, definitely want to watch out for INR values. Patient might be taking maybe on a something they might be taking valve, or they might have a valve for their heart. So understand the difference in the values for those goals between INR should be between 2 to 3, or whether it has to be 2.5 to 3.5. So at least know those differences there. So that's for that warfarin, monitoring the INR values. And then acute coronary syndromes like ticagrelor and clopidogrel. I have noticed, and I wanted to, I don't know if I already talked about it, but for clopidogrel, there is certain times there's an interactions. Patient might be having some kind of gastric acid issues, or they might have heartburn medication like omeprazole. Because of the omeprazole having that CYP2C19 inhibition, the clopidogrel is not, as a prodrug, is not going to break down and cause its effectiveness. So, or at least, do what it needs to do to make the blood thinner. So, just understand the interaction there. I think one of my videos already talked about it. It's there's a drawing on it, so just understand how that works there, the interaction between those two. Nitroglycerin, there's nitroglycerin is important also when patient is having like chest pain and immediate need, taking it. And also, understanding the different anginas the patient experience, stable and unstable angina. And then you got the, there's different types of angina. So that's important as well. So there's a video that describes on all that. So make sure you watch on that as well. Stroke, altered place. That's also very important, especially ischemic stroke. So, and also understand the acronym FACE for that, or FAST, actually FAST, I think, and also the medications associated with that. Definitely the main goal here is really just want to break those clots in the brain, so at least the oxygen can flow through. Dyslipidemia, we already talked about a little bit of statins, PCSK9 inhibitors, ezetimibe, bile acid sequestrants, fibrates, omega-3 fatty acids, niacin. So those are all important for dyslipidemia. Then all these antibiotics, bacterial infections, antifungals, opportunistic infections, HIV, hepatitis. Um, it's important to understand some of those classes of medications, how they differ between one disease state and another. But it's also important to understand some of the um, side effects associated with them and how it leads to them and how they work also in preventing those kinds of infections. So just take a look at that. Um, there's a pretty interesting acronym, I think, in one of my videos on HIV. Take a look at that. Bacterial infections and antibiotics by class, those antibiotics are very important. Also, one other thing, since we're on infectious diseases, is definitely making sure to keep um, to take a look at the patient's vaccinations as well to make sure the vaccines are up to date. You might get a question on the test on vaccinations, so it's a good idea to at least look over that to know which vaccines are live vaccines and which ones are not live vaccines, and the interval in which each of these vaccines should be used. Um, so know all of that. Does anyone have any questions so far? Okay, let's move on. Then the next one here is anemia, BPH, eyes, ears, gout, motion sickness, sickle cell disease. I think when it comes to motion sickness, Dramamine, scopolamine, meclizine, those are important. So know those. Um, vitamin B12, iron, folic acid, all of that for anemia is important. Um, I'm going to show you a diagram on the folic acid in a couple of slides, but it's actually to describe the importance as it is used, especially when it comes to the DNA part of the cell. Sometimes the programming, when it comes to programming in the genes and the DNA, folic acid is typically utilized to help, um, with those, with that type of gene programming or, in that part. So, because, and you'll see that in the later slides. The erythropoiesis stimulating agents like ESAs, that's important too, especially for someone not having very much uh, of that. So it's important to understand these things, especially when it comes to red blood cells, white blood cells, those kind of cell producing something that, if the bone marrow is lacking or something, then it's good to have these kinds of things. Um, I don't see anything that would stick out in this chart, but I'll let you know. And we'll be going over these topics again and again and again so you guys get more and more familiar with how everything's used. Acute and critical care. So things like, patient is having sepsis, for example, and they need some maybe urgent attention. They're gonna have to be started on fluids and vasopressins, and norepinephrine, those kinds of things to keep them uh, from going to septic shock. So important to understand those kinds of things. Propofol, amiodarone, neuromuscular blocker agents, cisatracurium, weight loss medications. I'm sure some of you uh, have seen now that they have approved the Wegovy tablets for weight loss. So some of you might have already dispensed it. Those are very expensive medications, but some patients are able to only tolerate the tablets versus the injectables. So I think that's a pretty good sign, a pretty good thing to have, especially for patients who are able to tolerate the tablets better than the injectables. Then you have phentermine tablets. Note that phentermine is a controlled substance, so just keep that in mind. Calcineurin inhibitors like tacrolimus, cyclosporine, those transplant medications is important too to prevent that um, rejection. Um, and then the corticosteroids for the inflammation part of it. I don't know if I talked about this with you all, but prednisone and prednisolone. Understand that prednisolone is the active form, so that just know those differences there. Tobacco cessation, we already talked about it. Osteoporosis, menopause, and testosterone use. Those kinds of informational use, especially alendronate. You might see the strains on these medications, one of them being once daily and the other one's once weekly, so note those differences there. And that's all I can think of here. Then gastrointestinal and others like constipation and diarrhea, Docusate, Dulcolax, Linzess, lubiprostone. I just take a look at these as well, especially stimulating versus like softening of the stool. So motion push method there. Then you have the sexual dysfunction agents like PDE5 inhibitors, travelers. These are things like pain relievers, antacids, antidiarrheals, things that you need to have when you're traveling. And then our urinary or incontinence, someone might be on mirabegron or flybegron. Anticholinergics. And there's GERD and PUDs. These are things like PPIs, the H2 blockers, and another one, the vasopressin, which is potassium competitive blockers. Be careful with the PPI though, especially when taking blood thinner like clopidogrel. Inflammatory bowel disease. And we'll talk about methotrexate in a minute. These are pain and oncology. I'm sure some of you have seen this chart on oncology, um, specifically going over like some of the toxic um, parts of some of these chemos, and understanding what those toxicities are in the pain medications like Tylenol, NSAIDs, opioids. Um, so just take a look at that. Look at all the toxicities of the chemos by looking at this chemo man, and that should be okay on that part. Then let me go back for a minute. I think rituximab, you should at least understand the CD30, or at least one of those, and paclitaxel. Yeah, so just, and also understand bleomycin too for the somewhere for the lungs as well. So then the diabetes, metformin, GLP-1 agonists, SGLT2 inhibitors, DPP4 inhibitors, insulin, sulfonylureas. Um, know these mechanisms. Know these mechanisms and some side effects on each of these. And for thyroid disorders like the T4 and T3 parts, levo and leothyronine, levothyroxine, leothyronine, and then the desiccated thyroid extract. So knowing that as well. And then common skin conditions like steroids, retinoids, and all of these other ones on the list. And then we're going to go over some video. We're going to be doing video reviews, so at least you guys have an idea of some of the topics that were discussed in the shorts. If you have not watched the shorts, we will go over it in these lectures now. So hopefully it'll help catch some of you up to the latest reviews that were already provided in the shorts. But it will be useful as a reinforcement tool or as a understanding of these concepts. So these are just some topics that were discussed already in the shorts and the videos, which you guys may or may not have seen, but will be discussed in these lectures. Continuous focused topic review. And we're going to be continually talking about this similar concepts, so you guys are better at understanding the medications and their mechanisms, and how it relates with those other interactions. So let's take a look at that. So for example, the first one here is the folic acid methotrexate. Some of you do not recognize this, but methotrexate is going to in higher doses going to prevent the usefulness of the folic acid, essentially, because folic acid comes from our diet or intestinal flora, and then it gets converted to the FH2. FH2 gets converted to FH4, and then that's being used as part of the DNA structure that contains the bases, adenine, guanine, thymine, and all of those things that make part of the DNA structure. So without that conversion from folic acid to FH2, it cannot do what it needs to do. And so there's going to be decrease in folic acid, which is why folic acid is essential, especially for patients taking methotrexate. However, for cancer cell, I think that would be very useful medication to weaken the cell or to, help with the cancer. So that's something to keep in mind, just and then leucovorin or folic acid or folinic acid is used to bypass the blocked enzyme. So if anyone has any questions on this diagram, just feel free to let me know. Next one here I want to talk about was the bacteria concept. There is gram-positive bacteria is going to typically stain purple, contain a thick peptidoglycan wall, and it works against the peptidoglycan cell. The penicillins work against it. And so what's happening here in the diagram is actually, preventing that enzyme. So autolysis can continue working. So that's essentially what's going on. It's trying to break down that cell wall. It's a cell wall synthesis inhibitor. That's what the penicillins are essentially doing. And now acetylcholines, this is just an illustration of how membrane depolarizes after binding of excitatory neurotransmitter. Now these diagrams are not, perfect, but at least they kind of can show you an illustrative idea as to the processes and how they work. So you could see here like acetylcholine. Acetylcholine is by itself, the receptor is not going to do anything. It's not going to depolarize the cell membrane. But whenever it is bound to a acetylcholine agonist, then it's going to allow the sodium to enter into the membrane and then cause action potential. So, things like that, they're just very basic concept, but at least you guys can see how processes like this work. Just going to briefly draw out a little diagram here. So whenever you have a little bit of depolarization, the action potential at the axon terminal, then you're going to it's going to cause that information to flow from one neuron cell to another. So that's essentially what the sodium is doing here. It's kind of turning on the switch to depolarize the membrane to cause that action potential. Then the GABA is going to inhibit that excitatory section by hyperpolarizing it after binding of the inhibitory neurotransmitter. So that's what the GABA receptor will do. If once it's bound to the agonist, then chloride's going to enter and then it's going to hyperpolarize. And then beta receptor and its functions. Just understand those differences between beta 1 and beta 2. beta 2 is going to mostly deal with broncho or vaso. Um, beta 1 typically one heart. Um, so it's like going to mainly deal with the heart. Beta 2 is typically with the lungs because two lungs, and then also the blood as well, the blood vessels. So just know those differences there. And in the alpha receptors, alpha 1, you already know epinephrine is one of those that's an alpha 1 agonist, and it's going to vasoconstrict. So you're going to see a lot of that in the blood, eye, bladder parts. And the alpha 2 is typically something like the CNS, the presynaptic nerve terminals. So clonidine, for example, is an alpha 2 agonist. So it's going to be used to lower blood pressure by interacting with the alpha 2 receptor in the central nervous system parts. Um, then you have alpha 1 agonist, which is going to vasoconstrict. And that's pretty much it. Does anyone have any questions? We will be doing some more reviews. I hope this has been helpful to you all, and thank you for watching. I hope you all have a good night. Um, and we'll talk again some other day. Thank you for watching, everyone.